AJT Journal Club to discuss the findings of the Consensus Conference on Heart-Kidney Transplantation published in AJT in February of 2021. My name is Darshana Dadhania from Weill Cornell Medicine, and I will be your moderator for today's Journal Club. Today's presentation will be delivered by Dr. John Kobashigawa, Thomas D. Gordon Professor of Medicine and Director of Heart Transplant Program at Cedars-Sinai Schmidt Heart Institute in LA. Dr. Kobashigawa will be sharing the findings of the ASC Consensus Conference on Heart-Kidney Transplantation held in June of 2019. Dr. Kobashigawa chaired the session, and I was a co-chair for the session. It was attended by approximately 40 individuals consisting of transplant surgeons, cardiologists, nephrologists, and ethicists. Following the manuscript presentation, Dr. Jane Farr, an associate professor of medicine at Columbia University, who is the medical director of the adult heart transplant program at NYP Columbia, and Dr. Xingxing Cheng, an assistant professor of medicine and transplant nephrologist with an interest in health service research at Stanford University School of Medicine, will join to address some of the challenging questions that you pose. During the presentation, please pose any questions you have in the Q&A window that is located at the bottom of your screen. Now, I'd like to turn the podium over to Dr. Kobashigawa to present the data. Welcome.
Thank you so much, Dr. Dadhania, and thank you to the organizers who put this together as well. So I'd like to speak on the Consensus Conference on Heart-Kidney Transplantation, as Dr. Dadhania had just mentioned, was published in the AJT in February of this year. And here's my disclosure. Well, heart transplantation is the therapy of choice for select patients with end-stage heart disease. Patients with severe heart disease frequently have concomitant kidney disease. Now, these patients with kidney disease who undergo heart transplant alone have reduced survival. Kidney failure is a predictor of morbidity and mortality in post-heart transplant patients. And simultaneous heart-kidney transplant has enabled the successful transplantation of patients with end-stage heart disease and concomitant kidney disease, with increasing numbers since 2010. But there is a clinical dilemma that we have in terms of when to allow the kidney to go with the heart. Now, the decision for simultaneous heart-kidney is challenged by difficulties in differentiating those patients with significant component of reversible kidney injury due to cardiorenal syndrome who may recover kidney function after heart transplant, from those with intrinsic advanced kidney disease who would certainly benefit from simultaneous heart-kidney transplant. So these are the questions that we ask ourselves. Who should undergo simultaneous heart-kidney transplant? How should multi-organs for transplant be allocated? And what are the management goals that we look at after the transplantation itself? Well, let's look at some of the data in terms of the prevalence of this process that we see. Now, this is from the database from the United Network of Organ Sharing. On your left is panel A. The number of simultaneous heart-kidney transplants have increased steadily since 2010. If you look at panel B on the right, you can see that heart-kidney transplant represents more than 5% of the total number of heart transplants performed in the United States. So certainly it is an increasing multi-organ system transplant problem. Now, not problem, but persists that we see. Now, what about the International Society? Well, this is from the International Society for Heart-Lung Transplantation that looks at multi-organ transplantation. Now, in green represents heart-kidney transplant, in yellow represents heart-liver, in red represents heart-kidney-liver, combination of three organs themselves, and in purple is heart and other transplant. But you can see that more than 90% of the multi-organ transplants are heart-kidney transplantation in general. And so how do these patients actually do post-transplantation? Well, when you look at the multi-organ transplant recipient, again, most of these are heart-kidney transplant, they actually have a significant increased survival compared to heart alone. You can see the p-value is highly significant. So what would be the reason for this? Well, one of the reasons may be less rejection. Now, this slide again is from the International Registry, and it shows the percent of recipients experiencing treated rejection, not treated rejection for antibody-mediated rejection, cellular rejection, or just biopsy negative rejection within 1 year by transplant type. And you can see that again, the multi-organ transplant have about 10% incidence of treated rejection, whereas heart alone is about somewhere around 24%, which is very similar to the randomized clinical trials that are ongoing. What about chronic rejection? We call it cardiac allograft vasculopathy, meaning blockages in the arteries of the donor heart. In green represents the multi-organ group, and in blue represents heart alone. And this is freedom from CAV. And you can see that the multi-organ group has greater freedom from cardiac allograft vasculopathy compared to the heart alone group. So maybe there is some sort of protective, immune modulated protection from the multi-organ transplant organs. Now, I put it here in terms of the table. I circled the cardiac allograft vasculopathy, so you can actually see the numbers that occur. Now, in the heart kidney transplant, they've actually divided into these specific multi-organ transplants. Heart kidney, 24% at 5 years develop cardiac allograft vasculopathy, but 29% develop it in heart alone. And again, this is significantly statistically different between the two groups. Now, what about immunosuppression? Well, I just show this slide just to show you that more or less patients are maintained on similar maintenance immunosuppression. Consists of tacrolimus, mycophenolate, and prednisone. In green represents heart kidney transplant, in blue represents heart alone, and in yellow represents heart liver transplantation. What's interesting is that although they see, or we see, less rejection in our patients, when you look to the far right in terms of prednisone, more patients in heart alone are weaned off corticosteroids as opposed to those in heart kidney transplantation in green, although they have less rejection. We'll think about that in terms of what we might do or suggest for our heart kidney transplant recipients in terms of weaning off prednisone. Well, let's move forward in terms of the Heart Kidney Transplant Consensus Conference. And as Dr. Dadhania had mentioned, this was put together in June 1st, 2019 in Boston, Massachusetts. And this was indeed a collaborative effort of the AST Thoracic and Critical Care Community of Practice and the Kidney Pancreas Community of Practice. And as Dr. Dadhania mentioned, this consisted of 40 experts from centers throughout the United States encompassing the fields of cardiothoracic transplantation, kidney transplantation, and medical ethics. Now, this manuscript was endorsed by the American Society of Transplantation and is a collective effort of the two community of practices that I had mentioned. The conference served as a forum to unify criteria between the different specialties and to forge a pathway for patients in need of dual organ transplantation. Now, here were the conference objectives: to develop needed guidelines for the interdisciplinary criteria for kidney transplantation in the combined heart kidney transplant candidate, to evaluate the current allocation of kidneys to follow the heart for the heart kidney transplant recipient, and finally, to develop standardized care recommendations for the collaborative management of heart kidney transplant recipients, including immunosuppression, monitoring, and treatment of post-transplant complications. This is a conference outline of what we actually followed in terms of our conference itself. We looked at the pathophysiology of heart failure and kidney disease. We thought it was important to understand the mechanisms, and certainly with cardiorenal syndrome. To look at the biomarkers to assess kidney function. What should we actually be following? Is it the creatinine GFR? By what equation do we use, MDRD versus the CKD-EPI equations? Relevant clinical studies, what makes sense in terms of a potential threshold by which to suggest heart kidney transplantation. As important were the ethics of multi-organ transplantation. Certainly, there are a lot of questions directed to us. And finally, we try to put it all together in terms of breakout sessions. We actually put together 3 breakout sessions. We balanced it with cardiologists, nephrologists, surgeons, ethicists, and all 3 groups, smaller groups, actually answered the same similar questions. And we all came back together to a large group so we can discuss all of these questions together and come up with consensus statements. Well, let me now start with pathophysiology of the cardiorenal disease leading to end organ failure. Well, heart failure and kidney failure share complex pathophysiological pathways that affect myocardial and vascular remodeling, endothelial cell dysfunction, as well as systemic neurohormonal activation, inflammation, and oxidative stress. The decreased kidney perfusion and venous congestion from severe heart failure will lead to reduced glomerular filtration and rise in serum creatinine called the cardiorenal syndrome. In the acute setting, Restoration of cardiac performance often results in improvement of kidney function. Now, I show you this slide here just to look at the mechanisms involved. At the very top, you see heart failure patient. The heart is actually failing right now. You have myocardial remodeling. You have an increase in wall stress, oxidative stress, inflammation, neurohormonal activation, circulating levels of cardiac troponin, and altered calcium handling. And that causes back of venous congestion. And that's probably one of the more important aspects of cardiorenal syndrome itself. You see this venous congestion on the glomeruli to your right. You have episodic sympathetic mediated fluid shifts from vasoconstriction of the splanchnic bed owing to intermittent hypoxia. And that will lead to more problems with the kidney, worsening renal failure. You get stimulation of the renin-angiotensin-aldosterone system and sodium and fluid retention and the like. That will lead to endothelial cell dysfunction, impairment of in endothelial nitric oxide dependent vasodilatation. You'll get acute endotheliitis, adverse effects on the myocardial fibrosis and cardiac function with hemodynamics and coronary and renal circulations impaired. And this is all going back in a vicious cycle, as you might imagine, but it gets more heart failure, begets more kidney failure in that sense. Now, does the kidney affect the heart? Well, absolutely so. The kidney disease can also affect cardiac function. Progressive kidney failure triggers metabolic disorders that can accelerate atherosclerosis and arterial calcifications, as well as precipitate uremic cardiomyopathy. Concomitant anemia in the context of kidney failure, as well as the presence of an arteriovenous fistula, can create a state of high performance volume overload that may be reversible after restoration. Now, it is important to emphasize that the trajectories of traditional biomarkers of kidney function, such as creatinine and proteinuria, may not necessarily reflect the spectrum of kidney dysfunction seen in heart failure and kidney disease. Now, I'll show you again a figure here where we can look at 30,000 foot view of kidney disease that can also affect cardiac function. You'll see at the very top here, the very top row, you'll see heart failure, and you'll see salt and water retention, and that can cause more volume and overload in the heart itself. Let me go to the far right, where you start to have more kidney damage, and you see this AGE accumulation. That's advanced glycogen end product accumulation. Now, these AGEs are pro-inflammatory and pro-oxidative compounds that play a role in high prevalence of endothelial dysfunction and subsequent cardiovascular disease in patients with CKD. So yes, there's actually an increase in atherosclerotic processes that do occur. And more than likely, it actually stimulates cardiac allograft vasculopathy, or chronic rejection, if you will, in our heart transplant patients. So altogether, you can see that with heart disease and kidney disease actually making things worse, uremic cardiomyopathy might occur, accelerated calcified atherosclerosis by itself. They can all lead to increasing heart failure itself, to actually cause heart failure death at the very bottom, and even sudden death may ensue. So you can see that, yes, the heart can affect the kidney, but the kidney affects the heart just as well. So which biomarkers are important to assess kidney function? Well, the evaluation of kidney function in patients with multi-organ failure is complicated because the formulas are largely based on the measurement of serum creatinine, and this assumes normal metabolism and distribution of creatinine. Now, in the disease state, there is an unpredictable and changing volume of creatinine distribution, a decrease in creatinine production due to decreased muscle mass, increased renal tubular creatinine secretion, and chronic malnutrition, which we see in cardiac cachexia. Therefore, in addition to using established predictors of creatinine clearance or glomerular filtration rate to establish the presence and severity of kidney dysfunction, it is necessary to develop supporting data from clinical assessment of the patient to evaluate for chronic kidney disease, what we call CKD. So what is CKD? Well, CKD is defined as having documentation of GFR less than 60 mils per minute on at least 2 occasions 90 days apart. Not all patients will have this documentation, so any history of kidney disease or kidney disease risk factors such as diabetes, hypertension will be helpful. Now, in addition, kidney ultrasound can be obtained to assess for kidney size asymmetry, shrinkage, or cortical thinning, indicating the diagnosis of CKD. Native kidney biopsies not always are feasible and can carry significant risk, but may be valuable in select clinical circumstances. Well, there's another term that's very important, and that is acute kidney injury, AKI. Now, it is important to consider patients with normal kidney function who develop sudden decompensated heart failure or cardiogenic shock. Now, in these patients, acute rises in serum creatinine are not uncommon, and in some cases, temporary dialysis may even be necessary. And these patients will have predominantly cardiorenal syndrome or acute tubular injury and will typically recover kidney function with heart transplant alone. So when we see a patient in our ICU who is coming in with cardiogenic shock, if we know that that creatinine kidney function was normal, maybe 2 weeks ago, maybe a month ago, even 2 months ago, we will really hold out from going to combined heart kidney transplantation, because we really believe, and our kidney brethren as well believe, that function of that kidney, the kidneys will return. So that's something to keep in mind as well. So is there a GFR threshold? What lower GFR threshold should warrant evaluation of pre-heart transplant patient for combined heart kidney transplantation? Well, let's look at some of the clinical studies that were performed. And to tell you the truth, we looked at several, meaning basically all the clinical trials that we could find. I'm going to showcase a couple of them here. A supplemental United Network of Organ Sharing database data set identified heart transplant and simultaneous heart kidney recipients from 2000 to 2010 to assess whether a threshold GFR could be identified that justified combined transplantation. 26,183 heart transplant recipients were assessed, of whom 593 were simultaneous heart kidney transplant recipients. All heart transplant patients had their estimated GFR calculated, and the patients were then grouped into GFR quintiles. Now, simultaneous heart kidney improved post-transplant survival in patients with GFR less than 37 mils per minute. And why that 37 mils? That's because that's where the quintile occurred and can be recommended in this group. So the group thought maybe this is a group that should undergo simultaneous heart kidney transplant. Well, let's look at the Kaplan-Meier of this study as well. In red represents that very low group, GFR less than 37 mils per minute. And you can see that group was statistically much lower survival when you looked at 12 months, 1 year survival from transplantation. Whereas the other groups were relatively close together. And so that's why it was purported that maybe this is the group to look at in terms of simultaneous heart kidney transplantation. So we looked at another larger database set, and this was again from UNOS. This was a large review of the UNOS database, pre-transplant GFR in patients greater than 18 years of age who underwent heart transplant between 1988 to 2013. Now in this study, patients were stratified into 5 different GFR categories, more groups that were rounded more or less, greater than 90 mils per minute, 60 to 89, 45 to 59, 30 to 44, and less than 30 mils per minute GFR. A total of 30,090 patients were included in this study. Of these, 46% and 39.9% had a GFR less than 60 mils per minute by modification of diet and renal disease, meaning the MDRD, and the chronic kidney disease epidemiology collaboration, the CKD-EPI equations respectively. Now, pre-heart transplant GFR by either equation was predictive of post-transplant heart transplant end-stage kidney disease and the need for kidney transplantation, with the highest risk in those pre-heart transplant GFR less than 30 mils per minute by either equation. Well, let's look at their Kaplan-Meier curves and see what they actually look like. When blue in either the MDRD group or the CKD-EPI group, you can see the blue the line is those patients with GFR less than 30 mils per minute. And whether you use the MDRD or the CKD-EPI equations, that group had the lowest survival overall compared to the other group, quite similar, to the other study, again, suggesting that this under 30 mils per minute group was truly one that would benefit from heart kidney transplantation. So let's now turn to the ethics of dual organ transplantation. And the next several slides will reveal what we were discussing. UNOS policies for organ allocation make an implicit distinction between life-saving organs meaning heart, lung, and liver, and those that are life-prolonging or that improve the quality of life for recipients, kidney and pancreas transplant. The most recent UNOS policy states, when multi-organ candidates are registered on the heart, lung, or liver waiting list, the second required organ, meaning the kidney in this case, will be allocated to the multi-organ candidate from the same donor if the candidate is registered at a transplant hospital that is within 250 nautical miles for heart of the donor hospital. And you can see the UNOS OPTN policy 5.10.c. So in practice, this means that a recipient listed for simultaneous heart kidney transplant, A, will have the primary life-saving organ allocated on the basis of the acuity of need, meaning our highest status, cardiogenic shock, is in the urgent status 1, 2, and 3. And B, will then receive the second life-prolonging organ, meaning the kidney, based on the geographic proximity to the donor, again, within a 250-mile radius of that donor hospital. Another clinically distinctive feature of simultaneous multi-organ transplantation is that this ethical reasoning is based on life-saving and life-prolonging views that support bypassing other potential recipients who may be on the waiting list for a life-prolonging organ, whereas the simultaneous multi-organ transplant recipient may have a more immediate need for that organ. Now, presumptive kidney transplant for patients requiring another life-saving solid organ is a rare instance when a future event is considered in the evaluation and allocation of an organ. In other words, our patients aren't on dialysis. Yes, they have severe kidney disease, and we're actually predicting that these are the patients that will develop end-stage kidney disease and therefore should have a kidney preemptive. So again, that's why there is some ethical issues in this concept as well. And finally, an obvious issue with utility in a multi-organ transplant patient is a single recipient. Rather than helping 2 or 3 people, only one person benefits. Typically, utility beyond the individual has not been considered in either candidate consideration or allocation policies. Now, the methods for determining social utility are imperfect, and they are not generally considered in transplantation decisions. Issues around fairness and distribution of organs across wait lists and different types of candidates warrant ongoing discussion and consensus in order to move forward in a sensible policy. Stay tuned, more to follow on that as well. Well, let me now turn to our breakout sessions. Now, as I mentioned, we had 3 breakout sessions that were evenly placed in terms of the number of cardiologists, nephrologists, surgeons, ethicists as well. And all 3 groups answered similar questions. The questions we looked at were one of utility, identifying who will benefit from simultaneous heart kidney transplant versus heart transplant alone. And that begins with predicting the outcome of native kidney function post-heart transplant, looking at the studies, 2 of the more relevant studies that I showcased, but there were many other studies that we looked at as well. The heart kidney work group felt the following factors to be important when evaluating a pre-heart transplant patient for a simultaneous heart kidney transplant. 3 areas: an accurate measurement of GFR or kidney function, presence of CKD, and acute injury, AKI duration and reversibility. Well, let me briefly talk about these 3 topics. In terms of accurate measurement of GFR or kidney function, 2 independent measurements of GFR was felt to be important, at least 2 weeks apart, to suggest to evaluate if patients meet the criteria for simultaneous heart kidney transplant. Now, given the absence of data, the first measurement can either be an MDRD or the CKD-EPI equations using standardized serum creatinine measurements. The confirmatory GFR measurement should be either a measured GFR or a calculation using serum creatinine and cystatin C levels in the CKD-EPI equations. Now, what about presence of CKD? Usually, CKD would have documentation of having GFR less than 60 mils per minute on at least 2 occasions 90 days apart prior to heart transplant evaluation. Without documentation of prior kidney function, long persisting risk factors such as hypertension, diabetes, proteinuria greater than 0.5 grams per day, and or ultrasound abnormalities, as we talked about, would also suggest CKD. In rare cases, if CKD is not established, kidney biopsy may be helpful, as we had mentioned. And finally, what about duration and reversibility of AKI? This is really probably one of the more important aspects. AKI duration was noted to be important as it is inversely correlated with a likelihood of kidney recovery. The heart kidney work group believed that AKI persists or AKI requiring dialysis despite optimizing cardiac function for a period to allow kidney recovery may belie underlying irreversibility and merit consideration for simultaneous heart kidney transplant. It is suggested that kidney recovery from AKI can take more than 6 weeks. Now, however, for our critically ill patients, those in cardiogenic shock, those on ECMO, for example, a decision on simultaneous heart kidney transplant may need to be made way before the 6-week mark has elapsed, as AKI is associated with waitlist mortality in our heart transplant candidates. So, in this situation where there is inadequate time to assess for AKI recovery, it is certainly incumbent that both heart and kidney specialists discuss the patient, weighing all factors. For example, perceived kidney reserve, recovery potential, risk, or presence of CKD in order to decide whether to proceed with simultaneous heart kidney transplantation. And so in the breakout session, we came together, and certainly there was collaboration between the heart and kidney specialists. So in the breakout sessions, the heart kidney work group suggested the following as we came together. Evaluation from a transplant nephrologist for simultaneous heart kidney transplant should occur when GFR is less than 45 mils per minute. Heart transplant candidates with an established GFR less than 30 mils per minute may be considered for simultaneous heart kidney transplant. Patients with established GFR of 30 to 44 mils per minute with firm evidence for CKD, such as small kidney size or persistent proteinuria greater than 0.5 grams per day, may also be considered for simultaneous heart kidney transplant on an individual basis. Now, for the remaining CKD patients with established GFR between 45 to 59 mils per minute, these patients may not be appropriate for simultaneous heart kidney transplant. Perhaps they may benefit from a proposed safety net policy. So what is this safety net policy all about? Well, one way to reduce unnecessary kidney transplant is to institute a safety net policy for heart transplant patients post-transplant who do not undergo simultaneous heart kidney transplant. This is a policy currently applied to kidney after liver transplantation. For pre-heart transplant patients who do not undergo simultaneous heart kidney transplant but undergo heart alone, a safety net policy after heart transplant modified from the liver kidney policy is now being suggested. Now, this safety net policy would provide that patients after heart transplant who underwent heart transplant alone, who then become on chronic dialysis or with persistent GFR less than 20 mils per minute for 6 weeks during day 30 to day 365 post-transplant, meaning in that first year, should be given priority for kidney transplantation. Donors with kidney donor profile index, KDPI, greater than 20%. So we're going to take these kidneys that have more extended criteria as opposed to the pristine kidneys that should go to the kidney waiting list itself. So this is something that is currently active in kidney liver transplantation, but they wait till 90 days. We put 30 days for a heart transplant, mainly because of the high acuity of our patient population. But again, something to discuss, and certainly something that UNOS is considering as well. Well, let me now turn to management of these simultaneous heart kidney transplant patient. Now, there's a lack of specific evidence on the benefit of induction therapy and an absence of consensus among centers performing induction therapy for simultaneous heart kidney transplantation. If induction is to be used, the choice of agent for induction therapy needs to be personalized based on the recipient's risk factors for infection, present or absence of delayed graft function, and recipient's immunologic profile. For example, for sensitized recipients and patients with delayed graft function, anti-thymocyte globulin, ATG, induction can be considered. Now, for recipients with a lower immunologic risk or at risk for infection, basiliximab induction can be considered. If ATG is used for induction, a delay in initiation of CNI of 1 to 2 days was considered safe, especially if kidney function appears impaired post-operatively. And finally, corticosteroids can be weaned in select low immunologic risk patients, simultaneous heart kidney transplant recipients, carefully weighing the risk versus benefit ratio. And what we meant by low immunologic risk, basically patients not having any rejection prior to weaning off steroids, those that are not sensitized, and those that did not have significant graft dysfunction. So let me go now to the consensus statements themselves, and there are 6 of these. Number 1, for accurate measurement of GFR, 2 independent measurements for GFR at least 2 weeks apart are suggested to evaluate if patients meet criteria for simultaneous heart kidney transplantation. Now, given the absence of data, the first measurement can be either MDRD or CKD-EPI equations using standardized serum creatinine measurements. The confirmatory GFR measurement should be either a measured GFR or calculation using serum creatinine and cystatin C levels in the CKD-EPI equations. Now, continuing with number 1 here, we'll go on to number 2. And these are the patients with CKD and patients with AKI that persist despite optimizing cardiac function for a period to allow for kidney recovery, are viewed as having kidney disease that is established and not reversible. Now, in situations where there's inadequate time to assess for AKI recovery, again, it is incumbent that both the heart and kidney specialists discuss the patient, weighing all factors in order to decide whether to proceed with simultaneous heart kidney transplantation. Now, here are the important aspects. Patients with established GFR less than 30 mils per minute may be considered for simultaneous heart kidney transplant, again, based on the studies that we had reviewed. Patients with established GFR of 30 to 44 mils per minute and firm evidence for CKD, such as small kidney size or persistent proteinuria greater than 0.5 grams per day, in the presence of stable hemodynamics, may also qualify for simultaneous heart kidney transplant on an individual basis. Continuing on with this statement 2, patients with established GFR of 45 to 59 mils per minute may not be appropriate for simultaneous heart kidney transplant. They may benefit from a proposed safety net policy. For pre-heart transplant patients who do not undergo simultaneous heart kidney transplant but undergo heart alone, a safety net policy for after heart transplant modified by the liver kidney policy is suggested. The safety net policy would provide that heart kidney patients on chronic dialysis or with persistent GFR less than 20 mils per minute for 6 weeks during day 30 to day 365 post-transplant should be given priority for kidney transplant with donors with KDPI greater than 20%. Here are statements 3, 4, and 5. Number 3, aggressive exploration and discussion for living kidney donation should occur contemporaneously with the evaluation process for simultaneous heart kidney transplant to maximize opportunities for evaluation and utilization of such donors. Simultaneous heart kidney transplant should be included in transplant center outcome metrics reported by the Scientific Registry of Transplant Recipients database, although the inherent increase in complexity and potential for complications need to be recognized, and there should be some degree of risk adjustment should be needed. And finally, in number 5, an age cutoff for simultaneous heart kidney candidacy was discussed in terms of, and also with donor candidacy, but it was not supported, by the group as a whole on ethical or utility principles. And then finally, number 6, the following are suggestions for simultaneous heart kidney transplant care. Since there's a lack of both specific evidence on the benefit of induction therapy and consensus across centers performing simultaneous heart kidney transplant, induction therapy will be left to the discretion of the transplant program. The choice of agents for induction therapy needs to be personalized and depends on the recipient's risk for infections, delayed graft function, and immunologic risks such as sensitization. For sensitized recipients, a delayed graft function ATG can be considered. And for lower immunologic risk recipients or those at risk for infection, basilizumab can be considered. And continuing with this last statement, based on kidney transplant experience, the consensus from nephrologists in the group was that calcineurin inhibitor delay is not necessary for kidney transplant protection. If ATG is used for induction, a delay in initiation of CNI of 1 to 2 days was considered safe, especially if kidney function appears impaired post-op. And there was no consensus on a specific goal of CNI levels for delayed kidney graft function, but generally CNI can be safely maintained through kidney dysfunction. If basilizumab is used for induction, CNI should not be delayed and dosed preferably within 24 hours of simultaneous heart kidney transplantation. And finally, it is safe or believed to be safe for corticosteroids to be weaned and select low immunologic risk patient simultaneous heart kidney transplant recipients after carefully weighing risk versus benefit ratio. So in summary, simultaneous heart kidney transplant can improve survival and the quality of life of patients with severe heart and kidney disease. From the patient's perspective, of course, receiving multiple organs in a single operation is the optimal resolution. However, in the setting of organ scarcity, simultaneous heart kidney transplant should be considered with respect to both the individual patient's need for the organs in question and the effect of simultaneous heart kidney on the kidney alone candidate's access to transplant. Certainly all the ethical issues are brought into play here and ones we should also discuss. And finally, it is hoped that the results of this consensus conference will provide a more standardized pathway for evaluating patients with simultaneous heart kidney transplantation and provide guidance to future research and policies to further refine simultaneous heart kidney transplantation and criteria. And what this is all about is basically setting a platform that we will all jump off and further refine our criteria as we move forward and get more data. And with that in mind, from sunny Southern California, I'd like to thank you so much. I'll give the podium back to Dr. Dadhania.
Thank you. Thank you for that excellent presentation. Allocation of limited resources is a challenging topic, and there are no perfect answers for sure. Now, I'd like to invite Dr. Cheng and Dr. Farr to turn on their video cams. There you are. For this panel discussion, we have a couple of questions in the Q&A, but I'd like to start off by asking Dr. Cheng. It's clear from patients with ESKD that simultaneous heart kidney transplant is a better option. The challenge is for those patients who have an EGFR somewhere in the middle, 20 to 30, are there good predictors for those patients who are going to have progressive decline in kidney function post-heart transplant versus those that will have improvement in kidney function post-heart transplant? And to link that discussion to one of the questions that was asked in the Q&A, why did the group, the consensus conference attendees, choose CKD epi over MDRD?
Sure. Thanks, Darshana. So regarding the predictors, I think the key point I want to make here is longitudinal data is better. A single creatinine without knowing the context, we can't even convert to an EGFR. Those all assume a steady state. So, and in all the studies I've reviewed, doesn't matter what biomarker is actually looked at, it's really the long-term trajectory that's going to give you the most information. That's in terms of other predictors, probably age and CKD risk factors such as diabetes, proteinuria, hypertension. These are the usual risk factors. Part of the complexity in the decision-making is that, you know, if we're trying to decide which patients will benefit from heart kidney, we need to know both how they will do with just a heart, but also how they'll do after heart kidney. Because if they'll do the same after either, then there's no, the kidney didn't add anything. And unfortunately, a lot of the predictors of outcomes, one will predict the other. Therein lies the challenge. About the audience question about using CKD epi rather than MDRD, the main reason for CKD epi was really that there are versions that incorporate cystatin C, which we feel was probably slightly better for patients who are cachectic, as most heart transplant candidates are. In terms of the actual studies that have looked at cystatin C and creatinine, honestly, when there didn't appear to be a clear winner, but the clear winner was having more than one measurement, Addie.
Thank you. I'd like to also invite Dr. Farr to address an ethical challenge in the allocation of kidney organs to individuals who don't yet have ESKD, while the number of patients awaiting a kidney transplant continues to increase. So question, what do you think would be more equitable to utilize the safety net option more frequently in patients with AKI and EGFR between the 20 to 30 cc's per minute rather than simultaneous heart kidney transplant? What are your thoughts, and how do we promote more utilization of the safety net option, as well as perhaps promoting living donor kidney transplantation post heart transplant? I think you have to unmute yourself.
Thanks. So I think there's probably three issues that are in those questions. The first is the safety net option. It seems reasonable. You say, okay, why don't we just get you through, see how it goes, and if it doesn't work out and you end up with kidney failure on dialysis post-heart transplant, then you have prioritization. Well, the first thing is how much prioritization. The second is no matter how much prioritization, you've got a patient now in renal failure with a central line going through hemodialysis and all the attendant infectious complications associated with that. And then in order to try to get as much benefit, you want to try to transplant them with a new kidney sooner rather than later. And then you're exposing them to more operative risks, maybe another set of inductions. And then depending on how sensitized your patient is, even though in aggregate, you're going to have a higher antigen load and maybe less rejection or vasculopathy. If you have any sensitization, now you're dealing with two different donors. So that's the first thing. On the other hand, with new allocation, one thing that we did look at just before this conference is that since new heart allocation in 2018, upwards of 8.5% of patients who are transplanted as status 1 or 2 got a heart kidney. So we're getting close to 10% of patients who are in shock who need a heart kidney. That's problematic because part of the reason they're in shock, some patients come in shock and they're new to us. So we actually don't have a great sense of how bad their kidney disease, although things like imaging and some collateral information can be helpful. But a lot of these patients have acute kidney injury. And part of the shock state is in fact, renal failure or multi-system organ failure. And these are patients, if we do know them and they're known to us in our clinics, we may be delaying VADs. We may have maybe offered them another type of mode to transplant a year earlier, but to some extent maybe allowed the shock state to facilitate transplant to avoid the VAD step. But what we did then maybe is then put them in a category that required dual organs. I think and there was a third piece to this.
Well, promoting, living donation as an option
absolutely.
Post.
Right, exactly. And that obviously just goes along with prioritization, that it would be better for patients to try to get their own donors for kidney. We have to remember all of those patients who've been sitting on kidney-only transplant lists for a very long time, being on dialysis sometimes for a decade, and the years of life lost. And even though you would call it a life prolonging transplant, at some point it has a mortality risk to it. And then you have to weigh that against the life prolonging aspect of a heart kidney. And again, the idea of younger kidneys going into older recipients.
Yeah, it certainly is a challenging ethical question. So Dr. Kobashigawa, I have some questions for you from the Q&A. I'm going to link these two questions together. It's related to less rejection in multi-organ transplant recipients. Question is there less rejection in individuals who receive a second organ from a different donor after heart transplant, so a kidney after heart transplant? And a more intriguing question is, what's the hypothesis behind decreased AR and CR, acute and chronic rejection in simultaneous heart kidney transplant?
Well, let me just answer by saying we don't know. Let me just start with that. What we do suggest, and we see this more in heart liver transplantation, where there are many passenger cells, and basically it's like having microchimerism that does occur in those situations where you have two cell lines that coexist. Now, whether that actually happens, in the heart kidney, we're not quite certain about that. Certainly, the more vascular organ appears to protect the less vascular organ, and that's why we get more protection from not only heart kidney, heart liver, and even heart lung, even more so with the heart liver and heart lung. And in fact, we don't even biopsy those patients because we don't see rejection that occurs with heart liver or heart lung transplantation. Just a spot biopsy maybe here and there, but by and large, they do extremely well. Even in chronic rejection, you'll see that occur as well. Now, what about, kidney after heart transplant where it's not from the same recipient? That's a good question as well. I don't know if we know that answer as well. I don't think we have enough data to look at that, but certainly this should be something, to look at in terms of the broader range. And maybe some of the registry data can look at that, but that's a very good question to ask, something that we should pursue as well. We did a nice study looking at intravascular ultrasound, our heart kidney transplant recipients versus heart alone. And intravascular ultrasound is pretty nice to look at what happens in the first year. When you think about it, if you're immune activated, you'll have more intimal thickening in that first year. And that actually predicts long-term outcome. The more intimal thickening you see in the first year, the more transplant vasculopathy by angiography and actually increased death, increased non-fatal major cardiac events occur at 5 years and later. And so that's why the intimal thickness is so important. So when we looked at the intimal thickness of heart kidney versus heart alone, yeah, sure enough, there was much less intimal thickening in the heart kidney recipient than in the heart alone. Again, suggesting that outcome could be beneficial in this cohort itself. And that's been borne out, just the registry data in terms of seeing less chronic rejection. So, there's still a lot of things we want to learn about, about all this in terms of the mechanisms, what is truly behind it. If we could figure this out, well, maybe that's our gateway to tolerance, acquired tolerance as well. Thanks.
So I have another follow-up question for Dr. Cheng. To start off with, to help decide about heart versus simultaneous heart kidney, what's the role of the kidney biopsy to potentially assess reversibility? And I'm going to link that to my question. There are a number of biomarkers that exist or have been studied in the setting of AKI. Are there any data on reversibility of AKI, and could those biomarkers be used in this setting?
Right. So, so the first thing about the biopsy, so there was actually a very nice paper in Transplantation that came out of Columbia, I believe, around 2010, 2012, where they actually did pre-heart transplant biopsies on 30 patients and used that to adjudicate whether the patients got a heart kidney or a heart alone. And it really was a nicely done study. I think they wrote out the criteria in there that they used, and pretty much everyone who got a heart alone, even patients with, reasonably depressed GFRs like 30, actually did very well after the heart transplant alone. So I think the main challenge with doing that is just the feasibility of the biopsy, especially now, at least at our center, most of the patients that we've evaluated are on at least one, if not 2 or 3 antiplatelet or anticoagulant, and many of them critically ill. So finding a safe window from the biopsy is a challenge. But I think if you're able to do it, it is a fantastic tool. Now, regarding biomarkers, this is I try to look at, I think of the biomarkers as there's the function markers, which is creatinine, cystatin C, and then there's also the injury markers, things like NGAL, KIM1, things that nephrologists are probably a little more familiar with. And the problem with the function markers is exactly that. It's a function marker. The predictability is really hard to decide. With tubular injury markers, surprisingly, reversibility is also not that great if you just look at injury markers. And the thing that I think we need is studies on actual recovery markers and repair markers. I think those will that in conjunction with injury markers will probably be the future to helping us prognosticate a little better. But right now, there's nothing really available.
Thank you. So I'll actually turn to Dr. Farr. Dr. Cheng mentioned some of the Columbia data, so if you want to comment on that, feel free. But I do have a question for you. Is there a particular management strategy you use in patients awaiting heart transplantation who have compromised kidney function to avoid further deterioration in their kidney function while awaiting? What strategies do you use? What strategies work?
So one I mentioned already, which is if you've got a patient with progressive heart failure, an outpatient with progressive end organ damage, whether that's kidney or liver or lung, pulmonary hypertension, to try to move to the VAD phase if you can. But the vast majority of transplants that we are doing for evaluation and urgent listing, or they're urgent listing. And so these are patients where the kidney function was one thing and 3 months later or 10 days later, it's another thing. And so for those patients, I would just say early aggressive temporary mechanical support, biventricular support, and then make some decisions as quickly as you can. That doesn't have to be transplant. It can be VAD, but if it's going to be transplant, try to stabilize and avoid renal congestion. And then of course, acute kidney injury on top of chronic. And then I guess get people transplanted before they go into kidney failure. And then of course it's the gamble. Does this patient need a kidney? Does this patient not need a kidney? And at least my observation, and we just sort of had increased some of our heart kidney transplants, it's the underlying issues like prior diabetes and hypertension. Even if you think you can get someone through, it's some of those comorbidities that seem to carry the day in terms of not recovering after transplant. Dr. Kobashigawa, what do you think? Am I allowed to?
Yeah, of course.
Yeah, I agree with Dr. Farr. Whatever she said. Well, you know what? We all try to optimize cardiac function. I mean, that's what the use of the mechanical assist devices, but we also use temporary devices. And these patients are critically ill, and we don't hesitate to put in an Impella, to afterload reduce, but also even putting an RP Impella on the right side, so we can unload the right side as well, because that's where the venous congestion occurs. That's where your cardiorenal, it really plays a large role. And so we can unload that right side as well as unloading the left side to increase, not only decrease congestion, but increase forward flow at the same time. We think we can really try to optimize our renal function. We actually do try to improve kidney function because our patients do better. They do better throughout the transplant surgery in the immediate postoperative period. Think about it. They're coming off the bypass. Their kidneys are taking a hit from the heart-lung machine. There's all kinds of bleeding that occurs. We're pumping in a lot of volume. And, sometimes the right ventricles, start to dilate. That just causes more congestion into the kidneys. There's a lot of things that occur. And then we throw on the CNIs. Oh my gosh, now we have even more kidney injury that occurs. And so that's why, we do get excited about all this. But what we do know though, that if we hang tough, we make sure that, urine flows, immediate post-transplant, that the kidneys will recover. And, so far we've been successful in doing that. Not all the time. And but I've seen kidneys come back as late as 6 months, after transplantation. So it's not just a one and done thing, after 30 days, although, we get concerned, but, we do see kidneys come back, and we just have to persevere and really, optimize our hemodynamics.
I think that does raise something because we don't really know how well doing a kidney transplant in a patient who's in cardiogenic shock or just coming out of cardiogenic shock with a new heart. The idea of doing a kidney transplant on a patient who is on ECMO or remains on ECMO right after a heart transplant, whatever it is that we're going to do, we have to make sure that that we actually are appropriately utilizing organs, in the best way. And
Well, that's
maybe a little too soon.
And that's a perfect cue to my last question, which is for Dr. Kobashigawa. And then actually, Brian is going to give some housekeeping details at the end of this session. So the question is this, we all have good intentions, but there's always potential for abuse. What safeguards would you put in to avoid overutilization of simultaneous heart kidney transplantation?
Well, I think the first safeguard would be the safety net. And because that would truly, diffuse that urgency to do the combined heart kidney transplantation, knowing that we have some backup, post-transplant. Where are we in terms of the heart kidney transplant in terms of the policy, the safety net policy? Well, when we talk to UNOS about that, right now, they're getting into active place right now is the use of continuous measures, right? In terms of lungs and kidneys, you have the lung allocation score, you have the kidney allocation score, but we don't have that in heart transplantation yet. Hopefully we will, at some point in time. But UNOS wants to use that score to actually stratify in terms of risk, for a heart kidney transplant initially, because maybe only in heart, if you're status 1, 2, or 3, meaning urgent status, would you qualify for a heart kidney transplant. That's one way to gatekeep, so to speak. But also that safety net may be predicated on the score as well. We'll have to wait and see. But first of all, all of these continuous measures have to be settled in terms of not only lung and kidney, go to heart and liver as well, and then settled in on the safety net policy. So I think we're probably a couple of years down the line in terms of actually getting that done, maybe even longer. But we'll have to wait and see what how UNOS responds to all this as well, and that will certainly help us. What also would be important is to look at our patients 1 year who get heart kidney transplant, look at them 1 year later and see, hey, are the native kidneys working? And then to look retrospectively and say, well, you know what, maybe we should not, obviously we should not have done that combined heart kidney transplant, and that'll give us more information in terms of the biomarkers. What were we missing, that these patients did fine, and their native kidneys did come back, Certainly you're not going to take that, kidney out, but, the kidney transplant out, but, at least we'll learn a lot of information for that alone as well.
Yeah. And just to add to that very quickly, I think it's, if we think about allocation, it's really kind of two questions we're looking at. One is what patients will benefit from a heart kidney over heart transplant alone. And then the second question is how much priority do we give these patients over kidney alone transplant candidates? And so, as the moving towards continuous distribution, there are different strategies we can work at on both the eligibility, as John talked about. In terms of the changing priority, Peter Rees and I just recently published a letter in the AJT also talking about some of the strategies we can do there. So keep your eyes out for the next few years.
Perfect. Well, it's almost getting to time. So I'd like to thank Dr. Kobashigawa, Dr. Farr, and Dr. Cheng for joining us this afternoon, and turn the podium over to Brian for some housekeeping details. But the conversation can continue on the AST Hub site at both of the community of practices. So please feel free to ask your questions of the experts. Thank you all for joining.
Thank you, Dr. Dadhania. AST would like to thank our panelists and our attendees for today's excellent session. For questions that we did not have time to answer, we will download them and send them to the panelists for further discussion and posting to the TCC and KPCOP hubs. Please remember to complete the evaluation survey following the session and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. The video archive of this session will be posted within 2 to 3 business days after the session is complete. To learn more about the AST TCC Community of Practice and the KPCOP Community of Practice, please visit myast.org/COPS or connect to the TCC and KPCOP hubs directly. Thank you all again for today's excellent session.